Transurethral incision of prostate. Through a cystourethriscope, the physician incises the capsule of the prostate gland and into but not through the true prostate to create a larger passage for urine. A small transurethral tissue sample from the prostate is often collected at the same time. The bladder is catheterized for the immediate postoperative period. Transurethral resection of bladder neck. The physician relieves an obstruction of the outlet of the bladder of a male patient. After the scope is passed through the urethra, instruments are inserted through the cystourethriscope to the target region. The physician excises the tissue responsible for the obstruction of urine flow. What is the correct CPT code for a transurethral resection of a bladder neck contracture by a hot loop and resectoscope? CPT code 52500, transurethral resection of bladder neck, separate procedure, is the appropriate code to report for the transurethral resection of a bladder neck contracture if the procedure is performed with a hot loop and resectoscope. Modifier 59, distinct procedural service, may be appended to code 52500 if the procedure was distinct and independent from the other service performed. Would it be appropriate to report codes 52450 and 52500 in conjunction with code 52648 during the same session? From a CPT coding perspective, CPT codes 52450 and 52500 are considered inclusive components to code 52648. Transurethral electrosurgical resection of prostate, including control of postoperative bleeding, complete vasectomy, metotomy, cystourethroplasty, urethral calibration and/or dilation, and internal urethrotomy are included. After preliminary cystourethroplasty, the physician passes the resectoscope under direct vision up the urethra to the region of the prostate. Metotomy, cutting to enlarge the opening of the urethra, and/or dilatation of the urethra may be necessary to allow the passage of the resectoscope. The prostate gland is removed in a systematic fashion by using a series of small cuts into the glandular tissue with an electrocautery knife. The resected tissue is removed and the area is kept clear by irrigation through the resectoscope. Bleeding is controlled by fulguration. A catheter is passed into the bladder and left in place for the postoperative period. Transurethral resection, residual or regrowth of obstructive prostate tissue including control of postoperative bleeding, complete vasectomy, metotomy, cystourethroplasty, urethral calibration and/or dilation, and internal urethrotomy are included. The physician inserts an endoscope through the urethra to remove residual obstructive tissue from a previous surgical procedure. After preliminary cystourethroplasty, the physician passes the resectoscope into the urethra to the prostate. Metotomy, cutting to enlarge the external opening of the urethra, and dilatation of the urethra may be necessary to allow the passage of the resectoscope. The physician removes residual tissue of the prostate gland through a series of small cuts. The resected tissue is removed and the area is kept clear by irrigation through the resectoscope. Bleeding is controlled by fulguration. A catheter is passed into the bladder and left in place. For removal of residual obstructive tissue after 90 days postoperative, report 52620. For removal after 1 year postoperative, report 52630. Transurethral resection of postoperative bladder neck contracture. Contracture of the bladder neck outlet usually results from scarring after a transurethral resection of the prostate gland. After preliminary cystourethroplasty, the physician passes the resectoscope under direct vision up the urethra to the region of the bladder neck contracture. Metotomy, cutting to enlarge the opening of the urethra, and dilation of the urethra may be necessary to allow the passage of the resectoscope. The scar tissue is incised at 1 to 3 sites or resected, using a cutting electrocautery knife. The operative site is inspected for bleeding, which is controlled by fulguration. A catheter is passed into the bladder at the end of the procedure and let in place for the postoperative period. Transurethral drainage of prostatic abscess. The physician inserts an endoscope through the urethra to drain an abscess on or near the prostate. The physician passes a cystourethriscope through the penile urethra to the region of the prostate and identifies the area of the abscess. A needle is passed into the abscess and purulent matter is removed by aspiration. The cystourethriscope is removed.